Good evening, everyone. Let me just start with this series. Yeah. Just a minute. Okay. So before I start with this, I welcome you all to Unacademy, and please, this is a very important thing. So please note the calendar. We have lot of exams for you, and do take these tests. They're very important for you. They're all free of cost, and they're going to be very beneficial for you. So let us just quickly start with this session. Okay, good evening, everyone. So we have also got the new batches started for you, and they are high yield revision batches, so you can join them. So let us quickly, without wasting any time. Okay. Identify the grade of biliary injury in this question. Amara says, gone through lectures, they have been great help. Please give lecture review points for endoscopy and GIT radiology and pediatric surgery. Sure, Amara, I'll just give it for you. Do it for you. Yeah, I'll do it for you. Before that, just answer this question. Identify the grade of biliary injury in this. So, what can you see in this? Let us first try to see the structures here. Yeah. Let us first try to see the structures here. When we talk about Amara, this is the first GI radiology part that we'll be discussing. This is the kidney. I hope you all can appreciate a kidney on this side. This is the duodenum. And this is your what? Bile duct. So this is the common bile duct. This is the common hepatic duct. So we have common bile duct, we have common hepatic duct. If you see what is this structure with something like this, the impressions like this, what is this? What are these structures? This is the drain. What is this impression? Try to look at this impression now. It is something like this. So what is this? Actually, this is the cystic stump which has been clipped. So this is what is your cystic stump. Yeah. And then as we go up, this is the hilum. This is the left hepatic duct, and this is the right hepatic duct. If you trace, this is the left medial and this is the left lateral. Similarly, if you trace this is the right anterior and this is the right posterior. And bache, if you see, there's a leakage of contrast from this. Students, if you see, there's a leakage of contrast from this. So I'll erase everything and now try to understand what is it. This is a right posterior duct injury. Yeah, this is right posterior duct injury. And not only there is injury with contrast leak. So this is actually a type C biliary injury. Is that clear? So what kind of biliary injury is this? This is a type C biliary injury. If we try to understand the concept of biliary injury, let us quickly see this. Okay. So now today we'll be discussing in this session the concept of biliary injury. I have discussed this a lot of times, but it's very important, and every time there are new students, So I frequently discuss this biliary injury topic. When we are talking about biliary injury, the classification that we have is known as Bismuth and Strasberg classification. So we have a classification which is known as Bismuth and Strasberg classification. Students always remember this Strasberg. Actually, Strasberg was the person who defined the injury part. He defined the injury part, and it was Bismuth. It was Bismuth who defined the stricture part. So stricture part. So this is a classification which describes both Strasberg and stricture and the injury part. So type A is a minor duct injury. It's a minor duct injury, or cystic stump leak. Cystic stump leak. So either there is a cystic stump leak or a minor duct injury. What is type B? Students, type B is defined as segmental duct injury. Segmental, it can be right segmental, it can be left segmental. So segmental duct injury without leak. So that means many a times we ligate and divide the segmental duct. And then we have type C. What is type C? It's a segmental duct injury. Segmental duct injury with leak. This is type C. And then what is type D? This is lateral wall. Bile duct injury. So let us try to understand what is A, what is B, what is C, what is D. Apart from that, the type E is describing the strictures. And when we talk about the strictures, we have E1, where the stricture is more than 2 cm away from the hilum. We have E2. Where the stricture is less than 2 cm from the hilum. We have E3. Where we have the stricture at hilum. We have E4. It is a segmental duct stricture. Without involvement of the hilum. So with hilar sparing. And E5 is defined as segmental duct stricture with involvement of hilum, with hilum involved. If you want to see this, let me show this in image, or let me just draw a diagram and show it to you. Bache, you have to understand that post cholecystectomy, this is the cystic stump. So you place the clips. If there is some leakage of bile from the cystic stump because of the loosening of the clips or the dislodgement of the clips, this is known as type A leak. Sometimes you might also encounter some accessory ducts. They might also leak. What are these? The classical example is the duct of Lashka. So duct of Lashka is a classical example. Type 2 is an injury where suppose you have ligated this. So you went for something, you put the clips here also, you have ligated and divided the hepatic duct. So right hepatic duct has been transected. So this is what is known as segmental duct injury without any leak. Why there is no leak? Because we have ligated and divided it. Taking it to be a cystic duct, a right posterolateral is often mistaken, and that is why the first step of safe laparoscopic cholecystectomy is the creation of the posterior window. If you cannot create a posterior window, you should not be doing any Kellogg's ligation, because unless you have confirmed that the structures that you are ligating is not belonging to the liver or the main biliary system, you should not be. Next is the third is segmental duct injury is there. Why? Because you have divided this duct, and that is why there is a leak, like in this case. This is type C. What is type D? If it is a bile duct injury, so this is a type D, lateral wall injury. Now when we talk about the strictures, if the strictures are more than 2 centimeters from the hilum, it is E1. If it is less than 2 centimeters from the hilum, it is E2. At the level of hilum, it is E3. Remember, if it is segmental duct stricture, with the sparing of the hilum, that is E4. And yes, if it is involving the hilum also, yeah, this is involving the hilum also, and it's a stricture involved, this is E5. You're getting E1, E2, E3, E4, E5. So if you see this question, this is a type C injury. I hope that is clear to everyone why it is type C. Let us go to another question. Let us try to understand. Okay. Answer me this question. A 38-year-old presents with erosion of the nipple areola complex and encrustation. Answer the following with respect to the image. Go on. It's a very easy question. I hope you can understand. This is a case of suspected Pigeons disease. Suspected Pigeons disease. So what is the answer? Pigeons disease, if you see, it is the skin manifestation of underlying malignancy. So skin manifestation of underlying malignancy. Bacho, if you see, this is very important and simple thing. That what has happened here? There is erosion of nipple areola complex. So erosion of nipple areola complex, and this is very important. Let us try. Very good Arpita, very good. Answer is B is the answer. So let us try to understand something about Pigeons also. What is Pigeons? Everything about Pigeons. So when we are talking about Pigeons disease, there are a lot of Pigeons in the body, but I am talking about Pigeons disease of the breast. Actually, this is an underlying malignancy which comes up like a volcano, lava of the volcano. Now, what is the theory? What is the concept behind Pigeons disease? It is transductal migration of the tumor cells. Migration of ductal tumor cells. So if we take this to be the nipple areola complex and these to be the ducts, suppose there is a malignancy here, and these are the malignant cells. So there will be a transductal migration of these tumor cells onto the surface. And do you know what will happen over the time? There will be erosion of the nipple areola complex. So there will be erosion of the nipple areola complex, and they may spread onto the surface. This is what is the classical explanation. So what is the presentation? The presentation, if you talk about, but if nipple areola complex is not involved, then it could be anything but not a Pigeons. So erosion plus encrustation. So erosion plus encrustation of nipple areola complex. Along with that, there may be discharge. Always remember, nipple areola complex has to be involved. This is associated with ductal cancer. Now, what ductal cancer? DCIS more frequent than invasive ductal cancer. Now try to understand one very important thing is, on histopath, on HPE, you get to see some special cells which are known as Pigeons cells. What is so special about Pigeons cells? They are oval and they have eosinic cytoplasm. Oh, things are okay. But they are the cells which stain positive for what? Cytokeratin Periodic acid shifts, PAS positive. Then Elsian blue, Elsian blue, Elsian black. Yes. What are the other tumor markers? What are the tumor markers? Students, they are positive for mucicarmin, mucicarmin. Then CEA, CEA, CA99, CA99. What else? What else, students? CA 15th or 15.3 or CA 27.2. Yeah. They're all very, very, very important. Apart from that, there are some new one also. Mammoglobulin, mammoglobulin. But when it comes to this silver dyes, yeah, but who stains with the silver dyes? Yeah, argentafin. It's the neuroendocrine tumors which stain for argentafin dyes, argentafin dyes. And always remember that Paget's is not a neuroendocrine tumor. Is that clear? No. Yeah. One very important thing is what is the basic management? What is the basic management? The basic management is it is BCS, breast conservation surgery, or simple mastectomy, In case of invasive tumors, in invasive CA, you have to go for MRM. So let us go to this question and see this. Answer the following questions with respect to image. Contains Paget cells? Absolutely true. Associated with DCI is absolutely true. Simple mastectomy is the preferred treatment? Yes. Argentafin dyes, they are seen for what? Carcinoids. They are positive for carcinoids. You getting? This is what is very, 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 very important. Very important. Let us do one more question. Answer me this question. A 26-year-old presents to you with the upper GI bleed. On assessment with the upper GI endoscopy, the following was the lesion noted at the level of antrum. Identify the lesion. Thank you, Amara. God bless you. Identify the lesion. And all except are true for the lesions. Let us see. But what is the diagnosis? Tell me the diagnosis first. Students, diagnosis. Excellent, excellent. The diagnosis is, we have a watermelon stomach. Watermelon stomach. And what is this watermelon stomach better known as? GAVE. This is known as GAVE. Gastric Antral Vascular Ectasia. Excellent. GAVE. Let us talk something about that and then we'll come back to this. Okay. Let us talk about this GAVE. When we talk about gastric antral vascular ectasia, since Amara, you have asked me to take some GI endoscopy based topics, that is why I have selected this here. Yeah. Dilatation at mucosa, this is what is. Let me tell you everything about this topic. When we talk about GAVE, what is GAVE all about? Yeah. It is the concept of GAVE. If dilated veins and capillaries. So dilated veins and capillaries at the level of gastric mucosa. Is that clear or no? So gastric mucosa, and this is what is hallmark. gastric mucosa. And location, if you talk about the location, it involves the antrum. And what is spared? Remember, what is spared? Answer is cardia is spared. Cardia is spared. Apart from this, what else do you get to see? Along with this, you get to see hyalinization of the mucosa. So hyalinization of gastric mucosa. So hyalinization of the gastric mucosa, and along with that, dilated veins and capillaries. Let us try to understand. So always remember dilated veins and capillaries. It is a female predominant condition. What is the classical appearance on endoscopy? On endoscopy, you get to see watermelon-like appearance. So watermelon appearance, and that is why it is known as watermelon stomach. So if you see this, if you see the inner surface of the watermelon, a cut surface of the watermelon, it classically mimics the gave. Is that clear? This is this red fleshy surface, irregular surface. This is what is. Next is, let us talk about the differential diagnosis. So we will take 3 conditions and we'll discuss. Very good, Arpita, very good. So we get to, the first is, we'll talk about gave. Then we will talk about Deulefois, and then we will talk about the portal hypertensive gastropathy. Portal hypertensive gastropathy. So the first concept is where and what is the defect. So if we talk about the defect, mucosal, so dilated mucosal veins and capillaries. If you talk about, like Amara, you were telling dilated submucosal vein, and this is where everyone plays with. So it's Deulefois lesion that you have to remember. It is dilated submucosal arteries. Are you getting? So dilated submucosal artery, this is what is known as Deulefois lesion. The next very important thing is, what do you get to see portal hypertensive gastropathy? Again, dilated mucosal veins or capillaries. What is the difference between portal hypertensive gastropathy and gave and Deulefois? Answer is location. But when we talk about the location of this is antrum, so the distal stomach, this is cardia, and this is also the proximal stomach. Yeah. The next very important thing is, what do you get to see on upper GI endoscopy? I have told you watermelon stomach. So watermelon stomach. The second is, what do you get to see in case of Deulefois? Answer is reddish brown nipple. Point number 1. And the second very important thing that you get to see here is caliber persistent vessel. So caliber persistent vessel, reddish brown nipple. Why do you get to see a reddish brown nipple? Try to understand. Imagine this is the mucosa. Yeah. And then under this we have the submucosa. At the level of submucosa, imagine there is a very thick vessel. There is a very thick tortuous vessel. You know that this is an artery, and this artery will keep on pulsating, and a time will come when it will erode into the wall. Of this, you can say, mucosa, and start protruding itself like a, see, this is a blood filled, so this is a reddish brown nipple, and over the time it can burst off and cause a torrential bleeding. What about the last one, portal hypertensive gastropathy, you get to see a snake skin appearance. A snake skin appearance. So snake skin appearance, this is what is very, 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 very important. So we have the concept of watermelon stomach, reddish brown nipple, or snake skin appearance. The next is association with portal hypertension. Which variety is associated with portal hypertension? So association with portal hypertension. Answer is no, no, and this is the one. Next is बच्चे effect of beta blocker. Effect of beta blocker. Who will respond? No response, no response, and yes response. Next is what about the management? What about the management? Here it is angioembolization. It is APC, endoscopic APC. What do you mean by endoscopic APC? Argan plasma coagulation. Argan plasma coagulation. What about this second one? बच्चे endoscopic clipping. If it fails, APC. But if APC fails here, you go for distal gastrectomy. Here again, if it fails, you will go for wedge excision of the part involved. What is the management of this portal hypertensive gastropathy? Again, students, you have to understand. The first thing is control portal hypertension, and then along with that, you can go for endoscopic clipping or coagulation. This is what. Are you getting this or no? So this is how we see this patient. So if you see this MCQ, dilated submucosal veins, absolutely wrong. Antrum is involved, true. Also known as watermelon stomach, true. Cardia is spared. This is true. So the option A is absolutely wrong. So this is all for today. Every day now at 10:15 I will be taking class. And if you enjoyed, do join the plus for more excitement. This is just the tip of the iceberg. Use the code Dr Dixit, or you can use the code Surgery Live. So you can use the code Surgery Live and download the app and make use of the special classes also. If you wish, you can or you should join the plus course also. Do follow me on Unacademy so that you don't miss notification of my classes, and do share the links with your class. Do share the link of the class with your friends, and do join Unacademy. Do give your feedbacks how you like the class in the comment section below. Till then, bye bye. So every day we'll meet at this time 10:15.